Okay, thank you very much. So I'll be talking of the work we've been doing on imaging the body and the liver. And I'd like to give you an example of what the UK Biobank is achieving. So I used to work for the Medical Research Council. We used to do fat imaging. It took us 10 to 15 years to do 2,000 people. The UK Biobank did that in the first 3 months. So that's the kind of scale of what we're talking about. And it's not that at the MRC we were very lazy, we were very hard. Yeah? It was very difficult to get the volunteers. The logistic of what's being done is absolutely incredible. So I'll start with the acknowledgement first. This is a collaboration. I have to thank Steve and Garrett and his imaging team, because it's actually fantastic what they're doing. To be able to do up to 17 people per day is absolutely incredible. Also, of course, Rory and Paul, who set up the whole imaging working group. But also we have a large collaboration both from universities and in the European Union, and I hope we'll be there in 2 weeks' time, to carry on doing some of the work of taking that imaging and making it a reality, making actually meaningful scientific data out of that imaging. And for that, we have been working very close with some of the companies here, and 2 companies I'd like to mention, Perspectum from Oxford and Amrad, who have been very key not only in setting up the acquisition, but also in the analysis, where industry is already pouring resources in trying to understand this data beyond just simply imaging. So the Abdominal Protocol, I'm not going to go into the science of the protocol, but basically things that you have to remember is that we were given 10 minutes. And they say, okay, you got 10 minutes to scan the body, because the heart takes 20 minutes, the brain 30 minutes. I'm not quite sure how they divided that. But that's why we only do from the neck to the knees. Because if I wanted to do the feet, I need an extra 2 minutes, and that was beyond my 10 minutes. But we get enough data to get lots of information about fat, muscle, and we focus also on the liver and the pancreas. So the first thing that you have to do when you got all these images is quality control. And this, again, Olaf from Amrad have been actually quite keen in taking this data and looking at the quality of the images that we are obtaining. And of course, we can get in A, we got the typical image we will get, and some of the errors that might actually happen. Like people, if you look at E, there's a metal implant. How many forms people fill in saying, do you have any metal implants? People say no. It's still some people will actually find metal implants on them. And some errors, like people keep their legs apart too wide, and therefore you get these little bites around the data. So we have to deal with that. But we managed to analyze the data, and this is some of the examples from Janet from Sweden, who actually analyzed lots of the first 1,000 volunteers. And you can actually see from body and fat and muscle, you can see that we get a 99.5% rate of success. I mean, that's actually quite amazing. And the same, very similar for visceral fat, slightly less of thigh muscle, but still very considerable. When we look at the analysis of success rate for fat in the liver, or iron or inflammation, we get very similar values, 99.9, 99.7%. Very, very amazing data acquisition. So what can we do with this? Okay, we can actually get what we call image-derived phenotypes. We can start understanding the scientific value of what we see. So the first thing that you do, and this is from one of our friends, is that you can make pretty images, which have actually value. So we can actually have here, we actually taken all the images and made it into 3Ds, looking at the fat and muscle. But we can then concentrate on specific areas of interest. We can look at volumes and quantity of, for example, external fat and visceral fat, which are actually quite important risk factors. We can look at liver fat and inflammation. We'll see later on some examples of this. We can do the same with the pancreas, the skeletal muscle, look at volumes of kidneys, and even the volumes of the lungs. And I'll show you some examples of this. Here is the liver. We actually taken all the images and actually extracted the liver, and we can actually measure the volume. Why do we want to know this? Well, when your liver becomes fatty, it increases in volume. If it becomes cirrhotic, it decreases in volume. We can begin to understand both the genetic factors and the environmental factors might lead to those changes. The same with the kidneys. You can actually measure each kidney separately or together and understand the volume and possibly the function. We can do the same with the pancreas or with the lungs. But let's go to something closer to my heart, which is fat, which is actually very interesting on. We can actually measure fat volumes and actually then relate it to specific areas of interest, the same with the muscle. So what are the ranges in the UK Biobank data? You can see in the abdominal subcutaneous fat, this is the fat from the top of your lung to the top of your femoral head, kind of in your hip. And you can see the ranges that we get from about half a liter to 22 liters of fat people carry. When it comes to visceral fat, we can go from 0.1 liters to 14 liters. And when it comes to the volume of muscle, it can go from 0.3, so that's a slight problem with that, to actually 10 liters as a mean value. So you can see the range there in the volunteers. You can take the muscles as a whole, or you can take individual muscles. So why would you like to look at a specific muscle? And I'll give you an example. We all talk, those who go to a gym, talk about your core muscles. These are the psoas muscle. We can actually not only measure it individually, but we can actually take the whole muscle area and measure its volume. And then we can actually relate it to specific changes in, for example, motion or the ability for exercise. And here I plotted basically the area of the psoas muscle against physical activity capacity, and you can see that the psoas muscle becomes a very good predictor. And why is this important? Because there are millions and millions of images around the world that contain psoas muscle that nobody uses. Where we can actually, from the UK Biobank, distill that information, and then people can use that as a resource to understand better physical activity. But we can also use this data to redefine, for example, obesity and metabolic risk. We know, for example, that over 2.1 billion individuals worldwide are characterized as overweight and obese. But we know also that BMI is not fit for purpose. The classification does not fully reflect the metabolic risk of an individual. And let me show you some example of this. Here we got, and this is from the ANRA group who kindly gave me the images, 4 obese subjects, BMI 30. And if you actually look at the level of visceral fat, a risk factor for the development of type 2 diabetes and coronary heart disease, you can see that it can go from 2 liters all the way to 12 liters of visceral fat with identical BMI. And this doesn't only happen in the obese subjects. If we look at people with a healthy BMI, these are BMI of 21, you can see that the levels of visceral fat go from 0.7 liters all the way to 6 liters. We can actually isolate muscle groups and then try to understand the effect of aging in relation to muscle function. And we can actually, again, go back to those 4 subjects with a BMI of 30, and if you actually look at the volume of muscle, it ranges from 13 to 14 liters all the way down to 11. So we can actually look at the sarcopenia process in the volunteers. The next thing that we can look at, other organs, specifically, for example, the liver. Here we can measure the amount of fat in the liver, we can measure iron, and we can measure actually fibrosis. And my colleague Banjo will actually show you some of the results that they obtained recently, and then I'll continue. Banjo, please.
Sorry, just to be an interloper, to give a few clinical examples. One of the questions for Biobank is, could it affect or beneficially affect the health of UK patients? And I just want to give you a few examples of how it has. So in the liver, we measure 3 things, fat, iron, and fibroinflammatory disease. At the moment, the gold standard to do this is a liver biopsy, which is both costly, expensive, and painful if you're the patient. We can now do that with imaging, and we've done other studies, and this is one of them, where we've shown that we can look at patients who are having biopsies and replicate the findings of biopsies and predict who's going to get outcomes. But these studies, as Jimmy was alluding to, are all quite small, 100 patients, 200 patients. With UK Biobank, we've looked at over 3,000 patients, and we've looked at the distribution of disease in this generalizable population. And we can use this data to beneficially determine what should happen to existing NHS patients and to plan care for future patients. So this is an example of the altruism that Rory was talking about earlier. So if you look just at liver fat on the left, you can see that irrespective of your cutoff, depending on the literature of 2% or 5%, there's a lot of patients in this study who have high liver fat. They have what we call steatosis or fatty liver disease. There are also a lot of patients in this sample who have quite high liver iron for all sorts of reasons which will come out in the next 5 to 7 years of research. And we've got a number of patients here with imaging evidence of liver disease. And when we plot them out, in the top right quadrant, you have the percentage of people in this sample that have non-alcoholic steatohepatitis, which is in the news a lot at the moment because it's one of the UK Chief Medical Officer's main concerns, obesity-induced liver disease. And we can now plot out the effects of that on the UK population. The biggest assumption here is actually the population of the UK, but if we call it 60 million, there are 1/3 people in this country with cirrhosis, and that's important because these patients are at risk of cancer and have a 30% chance of serious adverse events in the coming 3 years. And we can use that data now to look at clinical patients. So these are patients not in UK Biobank. These are patients that had scans as part of other projects or as part of clinical services. And we have the confidence now from that sample to say, this is a patient with early liver disease who doesn't need a biopsy because their LIF score is low. This, on the other hand, is a patient with fatty liver disease who needs to be prioritized because they're at the top end of the population scale and they've been put on the transplant list. And this is a patient who came as a normal volunteer on an entirely separate study, hence they're 22, and found out that they had very, very high liver iron, and with later checking turned out that they had a genetic disease called hemochromatosis. This patient's now being treated. It's a very simple treatment. He just has to give blood. But undeniably, his life expectancy has been improved by the findings that we generated from Biobank. So for all the Biobank participants in the room, that's one life prolonged already.
Thank you. And just to finish, some interesting findings. So I just started doing some quick correlation. One of my students, Warid, they took some of the liver data and looked, and the self-reported number of days people go for a walk. And you can see there is a negative correlation, i.e. the more you walk, the less liver fat you have. The other non-surprising thing is the more time you spend watching television, the more liver fat you have. So this is a kind of generalized things that we can find. So proving what we expected, but also new data. And I'll show you two things that one of my colleagues at King's, Nicola Guess, have been doing, is that what type of bread you eat decides the amount of liver fat. And this after we took into account BMI, age, gender, ethnicity, and physical activity, you can actually see whether you eat high or low fiber bread will actually determine how much liver fat you have. And the same is true for fiber in your cereal. And like that, we got many other stories that we can tell you, including cheese and milk. But we'll leave that for next year. Thank you very much.
Thanks very much. And moving swiftly on